going to talk about ASDs. Let me get started with that. I'm just going to put this on full screen. So we're going to talk about the diagnosis and treatment of atrial septal defects. Now this will be an interactive question and answer, so please get ready one person to type in the chat box with an answer to everyone so everybody can see it. So as you know, an ASD is an opening between the right atrium and left atrium, and the definition is that it is something other than a PFO, because a PFO is not considered an ASD. And what is the size of a connection to the right atrium that we call PFO? What is a patent foramen ovale? What size? Anyone would like to put that in the box? What size is a PFO? Anyone? Less than how many millimeter is a PFO? So ASDs are among the very common heart diseases. 10% of all heart diseases are ASDs. So less than 3 mm. So definition of PFO would be 3 mm or less would be. So if it's 4 to 6, it's actually a small ASD, and we'll go over those definitions. But 3 mm or less would be a PFO. Now ASDs, as you know, are more common in females, 2:1 ratio, except in sinus venosus ASD where it's a 1:1. And again, pulmonary vascular disease, more common in females. And we have known about ASDs from 1900. So what are the types of ASDs? So we have your ostium primum, right? Which is between the RA and the LA at the level of the valves. You have ostium secundum. Ostium secundum is your most common. But then you've got sinus venosus and what's called unroofed CS, which behave like an ASD. So when we look at this, so when you hear this, let me just get my laser pointer on. Here's the laser. So you see this is superior vena cava. When you have an atrial septal defect there, it is a sinus venosus ASD. These ones can get missed because the cardiologist has to look high up. They have to look towards the SVC to pick this up. So if you have a patient who has the echo report is saying RV dilated, no ASD, you should send them back to look for this type, the sinus venosus, or the what's called inferior sinus venosus, which is where the IVC comes in. Now, secundum ASD is right in the middle of the septum, right? We know that. And then you've got where the coronary sinuses, see here, so the coronary veins come into coronary sinus. Coronary sinus enters into right atrium. What if the roof of the coronary sinus had a hole in it, right? So now instead of veins coming through LA to RA, the blood can go from LA through coronary sinus to RA. And that is what is called a coronary sinus defect. Now you look here, this one which is right near the mitral valve, tricuspid valve, that is your primum ASD, or what we call partial AV canal, and it's right near the valve. So that's the one that has the problem also with the valve. You can get a cleft mitral valve with regurgitation. So these are the types of ASDs. Basically secundum most common, then primum, and then you have your sinus venosus, and lastly very rarely is your unroofed coronary sinus or your coronary sinus ASD. Now, when we say small, moderate or large, right? So we said 3 mm, less than 3 mm PFO. And it's important to note that 1 out of 5 people in the world, 1 out of 5 people in the world, 20% of the world population have a PFO. And the reason this is important is many times on echo, 5-year-old, 10-year-old, 10-year-old, the report will come back PFO. And parents have no idea, they're like, so it's very important to tell them 20% of the world population, if we have 5 people in the room, 1 of us will have a PFO, nothing to worry. The only time we close a PFO is if they ever have a paradoxical embolus, if there is some right to left shunting at the PFO level. So that is about PFOs. The thing with the PFOs is when you have a PFO at birth, many of them can get smaller. But remember, 1 out of 5, they're not going to close. Now, when we talk of small ASD, we put more than 3. So basically 4 to 6 will be small. And when we put moderate, we say 6 to 12. And when we put large, we say more than 12 millimeters. But the difference between small and moderate, anyone, what is the difference between small and moderate apart from size? A small ASD versus moderate ASD. What is the difference apart from just the size? Let us say, so anyone, what do you think could be the difference? Maybe from echo, from anything. So where does the ASD go? It goes from left to right, right? So let's go to the physiology. It goes from left to right, right? So when it goes from left atrium to right atrium to right ventricle to lung. So what happens? If the ASD is of significance, which means if it is moderate or large, the right atrium, right ventricle will become dilated. If it is a small ASD, right atrium, right ventricle will be normal sized. So you cannot say 5 mm ASD, RARV dilated, but call it a small ASD. It doesn't gel, right? You've got to say 5 mm ASD, right atrium, right ventricle, normal sized, normal lung pressures, then it is small. Is that clear? If it is 6 mm, is it small? Is it moderate? Right? It is sitting on the cusp. So if it's got RARV dilation, it falls into moderate. Normal RARV falls into small. So that is why small ASDs with normal right atrium, right ventricle size, normal lung pressure do not need intervention. Why is that? Because 1/5 of the world has a PFO. PFO also is small. It's a left to right shunt, but there's no RARV dilation, right? So the only reason we close ASDs when they are moderate or large is to reduce that right heart dilation. So the difference between small and moderate apart from size is presence or absence of right heart dilation. So I'm going to start now with an opening quiz, and I want you all to answer this because we'll do the same questions at the end of this class. So when would you close a secundum ASD? What age? What age would you close a secundum ASD? Anyone? So just have one person type. It's okay if it's right or wrong. This is really, let's get a sense of, what is the understanding in the room. And then we'll move on to, by the end of it, you'll have a clear understanding of why we do what we do. So when do we close? So, okay, so you said 2 years. What about if a baby is asymptomatic, could you wait till 5 years? So the 2 is okay, but really there is a range for secundum ASD, and we will go over that, and it's 2 to 5 years. So before they go to school would be your maximum limit. When would you close sinus venosus ASD? Sinus venosus ASD, around 4 to 5 years. And I'll go into why it's different. Primum ASD, when would we close primum ASD? Anyone? Primum ASD? Okay, so 1 to 2 years. Now, what are the typical symptoms in a 3-year-old with an ASD? Anyone like to answer that? Typical symptoms in a 3-year-old with ASD. No trick questions. This is just, in a 3-year-old, what symptoms would they have? Or do they not have symptoms? Are they asymptomatic? What's most common? I'm not going to move to the next question till everyone answers. Okay, so they can be asymptomatic, right? So asymptomatic, or some of them can present with respiratory infections and not such great weight gain. More commonly, they don't have symptoms, but they may have frequent respiratory infections. Now, when in an ASD, which is moderate or large, when do typically the symptoms occur? What do we tell patients? When will typically, say they are asymptomatic at 3 years, when would they have symptoms? At what age would they get symptoms? Anyone? Only column is answering. We need competition here. So when would a typical asymptomatic large ASD get symptoms? Yes, in third or fourth decade. And we'll go over that in when they have PH. Now, next question. Can you close an ASD without surgery? And which type of ASD can you close without surgery? Anyone? So you can close without surgery and secondum ASD, right? By putting a device. Can you name some syndromes associated with ASDs? Syndromes associated with ASDs? Any syndromes you know of? So Downs could have which type of ASD? Primum. Any other syndromes? Any other you all know of? So Downs, primum ASD, Holt-Oram syndrome, secundum ASD, Noonan syndrome, secundum ASD with PS. Okay, so now let's go over these. Now, cardiac lesions associated with ASDs, there are quite a few, but what we look for is really mitral valve prolapse, mitral regurg. They can sometimes have PAPVC, pulmonary veins connected. They can have a Lutembacher if it's with rheumatic mitral stenosis. So these are genetics, as I said. With Downs, you can get primum ASD. What is the diagnosis here? This one, middle one, what is the diagnosis? This one, anyone? So Noonan's, you can get secundum ASD along with pulmonary valve stenosis. And third one is Holt-Oram. Anyone for what is the genetics in Holt-Oram? Genetics in Holt-Oram? So in which mutation do you get in Holt-Oram? So in Holt-Oram, you get your radial abnormalities and you can get along with that secundum ASD, and they generally get a mutation in the transcription factor TBX5. And TBX5 is needed for development of both the heart as well as upper limb. So that's why they'll end up having heart problem as well as upper limb, because it's the same transcription factor. Okay, so all clear. This is genetics in ASD. Now let's move to the natural history. What happens with ASDs? If it's less than 3 mm at birth, 100% is likely to close because it's already a PFO at birth. So most likely it's going to close. If it's less than 5 mm at birth, 90% are likely to close. Okay, less than 5 mm. If it's 5 to 8 mm at birth, 80% are likely to close. So if it's 10 mm at birth, it most likely won't close. So this is important to note that if it is, the smaller it is at birth, right, the more likely it is to close. Now, when we talk of ASDs, right, we say someone needs to mute themselves, I think. Can we mute one of the centers? Just see Abhilash. Background noise. Abhilash, can we mute them? Yeah, just mute. There's one center talking. Just mute them. Okay. So the smaller it is, just mute everyone. Yeah. The smaller it is at birth, the more likely it is to close, right? Remember with ASDs, either it can close or it can become smaller, right? Or it can even increase in time. And this is important to know because, you know, when you see an ASD, Parents will say, will it close? Now, how do you can say maybe it will close, and this is the incidence. But if it may close, it may become smaller and become a PFO or a small ASD. But because the left to right shunt, it can also stretch. So sometimes it can increase in diameter. So it is not like, oh, today it is 8 mm. And if they come after 1 year, it is 12 mm. It is not that the cardiologist made a mistake, because ASDs can increase with time. Now, over time, they basically develop Eisenmenger's syndrome, and that is the cause of morbidity. So if you look at the pressures when you're born, right? LA pressure, say, is 6 millimeters. RA pressure is 2 or 3. So you have a left to right shunt. At that time, lung pressure is normal. A normal lung pressure is 25. Then what happens if you keep having that left to right shunt over years? So with ASD, it's a low pressure system, right? LA is 6 or 7. RA is, if it's a large ASD, RA is also 6 or 7. So it's a low pressure left to right, but high flow. So you get lung pressure starts going up over time. Then when they are in their third and fourth decade, now look at the lung pressure here, 100. LV pressure 100. So it becomes a systemic pressure. The shunt starts going more and more right to left. They start becoming blue. So this whole process, because the atria are a low pressure system, this process of normal lung pressure to high lung pressure takes many years. But in Indian studies coming out of Vellore, we have shown that 10% of children less than 10 years of age developed pulmonary hypertension. So while we say yes, most likely they will develop pulmonary hypertension in the 30s and 40s, there is a percentage of kids who develop this lung damage, develop this higher lung pressure early in life. And that is why intervening on these kids at the right time is very important. Now, let me ask you all, what do you think is the cause of mortality or morbidity in an ASD? We said one is lung hypertension. What else? What else causes their morbidity, mortality? Anyone? Come on, come on. I'm not going to let you sleep. You have to answer. Causes of morbidity, mortality? What do you think? One is, we said, pulmonary hypertension. Okay, arrhythmia, yes. They could have arrhythmia. What else? So because of the right heart dilation, they can have a tachycardia. So that could be one. What else? So because of the pulmonary hypertension, they get right to left shunting, they get cyanotic, they get polycythemic, right? So that can lead to brain abscesses. You can have, because of your your ASD, you can develop paradoxical emboli, right? You can have congestive heart failure. Eventually, the pulmonary hypertension, the right heart will fail. So you can get pulmonary artery thrombosis. So that's why their life expectancy gets reduced. So basically, the life expectancy is reduced by 0.7% per annum in the first decade, and then you're reducing it by 7.5% per annum in the sixth decade. So it's a normal, all of us today could live to our 70s. If we don't treat an ASD, they're going to live till their 40s. So we are reducing their life expectancy over time. Okay, all clear on this? So this leads us to why we should intervene, right? Now, before we get to intervention, what are the murmurs in an ASD? How will we pick up that there's an ASD? So we know if we don't treat an ASD which has right heart dilation, we're going to get pulmonary hypertension and we're going to have issues in adulthood. So how will we diagnose? Can anyone name the murmurs in an ASD? When you put your stethoscope, what will you hear? What murmurs? Anyone? Okay, so ejection systolic murmur, you put it at the pulmonary area. And why is that? Because the blood is going left to right at the atria, LA to RA, RVPA, right? So at the pulmonary valve your pulmonary valve is whatever size, and you've got more blood going through it. You have SVC, IVC blood going through it, and you have the left to right shunt. Then yes, you can get a diastolic murmur at the tricuspid valve because all that blood from LARA first goes across tricuspid valve. So you can get systolic ejection murmur at pulmonary valve. You can get diastolic, mid-diastolic murmur at tricuspid valve. Then if you get pulmonary hypertension, you can get a pulmonary regurgitation murmur, diastolic. And you get in when you have PAH, when you have pulmonary hypertension, that diastolic murmur, which is very high frequency, because it's a high pressure murmur. What is that called? High frequency early diastolic murmur of pulmonary hypertension is what? With pulmonary regurgitation. What is the name of that murmur? Anyone? PG's in there? So that is the Graham-Steele murmur. So these are the murmurs you can get. Now, let's do a case. You have a 5-year-old, no symptoms, referred for a murmur to cardiology department. Baby's pink, quiet precordium, no heart failure, wide fixed split second heart sound, and a 2/6 systolic ejection murmur at the pulmonary area. What's your diagnosis going to be? You're going to think this is an ASD, right? Now, why do you get a fixed S2? Why do you get the wide fixed split? And how do you hear it? You put your stethoscope at the second left intercostal space. You let the patient breathe normally. And you'll continue to hear the truck, 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 truck in inspiration and expiration, right? It'll be the same. You don't have to ask him to breathe like this. Let him breathe normally. But the difference between that split that you hear will remain constant. Now, why is it fixed and wide? So what is the normal cause of a split? Normally, aortic pressure is 100, right? PA pressure is 20. So what will happen? Which valve will close first? So when you breathe, the venous return comes back from SVC, IVC, goes to right heart. Increased flow through the pulmonary valve. Aortic pressure is 100, PA pressure is 20. So the aorta will close the aortic valve, right? So aortic valve closes, then all this flow is coming through the pulmonary valve, the pulmonary artery pressure is low. So pulmonary valve will close later. That's a normal split, right? Now, when the person expires, breathes out, your intrathoracic pressure goes up, the pressure in right atrium goes down, there's less venous return, right? So normally your split will narrow in expiration because you've not got so much flow going across it. But when you have an ASD, all that LARA shunting is still going on, right? Even in expiration. So there's still increased flow across the pulmonary valve. So even in expiration, the split is wide. That is why it is wide and fixed. Normally in normal people, you do get a fixed split, but it is wide and it varies. Here it doesn't vary. So listening to that wide fixed split, and kind of getting in the habit of hearing it is a very good clue for an ASD. Now you think this is an ASD clinically. Let us say he's walked into your pediatric office. Before you send for an echo, how can you differentiate which type of ASD this is? Is it secundum? Is it primum? Is it sinus venosus? Is there any test you can do to differentiate these three types of ASD? So that when you send to the cardiologist, you are looking pretty clever, right? You're saying, I think it's an ASD, I think it's this type of ASD. So what test can you do? It's a very simple test, 100 rupees, and it can help you diagnose which type of ASD. Anyone? So, an ECG. Yes, an ECG. Now, sinus venosus, yes, maybe you get mild desaturation. You may or may not, but certainly you can check your SAT. But an ECG will help you differentiate. So if you look here, now if this patient, I don't know, we've done some ECG reading classes, right? So try and read this ECG. So it's a QRS upright in 1, QRS upright in AVF, so normal left axis, right? P, look at the P. Upright in 1, negative in AVF, right? So if you can look at these two leads when you look at ECGs, 1 and AVF, they give you a lot of information. So now it's upright in 1, it's negative in AVF. What does that tell you? That the sinus impulse is coming from down below up, right? So if this patient had an ASD, which ASD would it be? So which ASD gives you a superior axis of the P wave? Anyone? So this, well, let's go over primum, but the deviation of P wave, okay, is sinus venosus ASD, and we'll go over primum. Now, if this patient had an ASD, which ASD would it be? So you've got deeper QRS in 1, right? So you've got a right axis. You've got your RS prime in V1, right? You have a normal P wave axis. So which is this classic for? This is what's called an incomplete right bundle branch block, right? Look at this. Look at V1. V1 is very good for ASDs. So which would this be classic for? This would be a secundum ASD, right? Right axis, RSR prime V1, right bundle branch block. Now this one, what is happening in 1? It is upright. In AVF, it is QRS is negative. So this is a superior QRS axis, right? Look at P axis, upright in 1, upright in AVF, normal P axis. So what is this? This you see where? This you see in ostium primum. So it's very, very easy. To diagnose the ASD, you look at 1 and AVF. Okay. If P is negative in AVF, it is a superior axis of P wave. That is sinus venosus ASD, because sinus venosus is here. Where the SV, where is the defect? It is where the sinus node sits, right? It is at the SVC-RA junction, that area. So you don't have a normal sinus rhythm. You have a low inferior rhythm. If the QRS is negative in AVF, this is a superior QRS axis. This goes with primum ASD. If the P axis is normal, but you have right axis deviation, that goes with secundum ASD. Okay, I hope this is clear. So we're going to do another case. Now, it's a 1-year-old. 2/6 systolic ejection murmur, wide split second heart sound. So clinically it is ASD, but you have checked saturation. Saturation 85%. Now what do you think? This is a 1-year-old. So we are not saying he's got Eisenmingers, right? In 1-year-old. So what can give you features of ASD, but he is? So yes, could be TAPVC, total anomalous pulmonary venous connection, which is not obstructed, because obstructed TAPVC does not present like an ASD. They will be sick, small heart, wet lungs, but a non-obstructed TAPVC can present like an ASD. So that's one option. Any type of ASD you know that can present like this? So there is what is called a common atrium. So if you look at this common atrium, this is your mitral valve, tricuspid valve, LV. The whole atrial septum. So what happens when blood comes from SVC, IVC, pulmonary veins, it all mixes inside the atrium. It all mixes in there, and that's why you have desaturation. So features of ASD, but blue, think of also common atrium. You can think of unobstructed TAPVC as well. Okay, so now we shall move to when would you close, right? So secundum ASD, when would you close? First slide that we discussed, we would close between 2 to 5 years. Now, why 2 to 5 years, right? Okay, why to close it all? Let's first go to why should we close an ASD? Because this comes up a lot, especially when you have a child without symptoms. You don't have symptoms. He's running, he's playing. Parents say, why should I close? Right? Pediatrician is like, yeah, you're right, you're looking good. So it's important to understand why we are closing it. Now, when you have a RA-RV dilation, right? And you continue with right heart dilation for 10 years, 15 years, 20 years, 30 years. One issue, as we all know, is development of pulmonary hypertension. That is one dreaded complication. And when the patient lungs are damaged, there is anyway no chance then of operating. So you have reduced his lifespan. So that is one. Now you may say, okay, why don't I wait till 10 years? Anyway, there's no pulmonary hypertension. Let me wait till 10, 12 years and operate. The reason is that the longer you keep the right atrium, right ventricle dilated, when this child becomes an adult and gets coronary artery disease and gets his lifestyle diseases and his diabetes mellitus and his hypertension, right? This heart that was dilated for a long time, even if you operate now, say at 12 years or 15 years, he had 15 years of his myocardium being stretched. 15 years of his heart was under load. So it is never a normal heart. So even if you close the AST when he's older, he may be okay for many years. He will leave your hands. He will go to adult physician. But when he becomes an adult and gets coronary artery disease, his right ventricle will not tolerate it as well as a normal person's right ventricle. So we do them a big disservice when we delay intervention too long. Yes, we don't want to do it too early, but there is an optimal age that we need to do it in, and the maximum age is 5 years. So the maximum age for intervening would be 5 years. So if they're symptomatic, like let's say they're having respiratory infections, not gaining weight, all of that, then you can do it at 2 or 3. If they're asymptomatic, you can do it at before they go to first standard by 5 years. And the reasons to do it are this. Okay, all clear on this? Now, I'm going to ask you options to close. So our first slide we had said, remember the quiz, surgical or device, right? Both. Now, let's do a few cases. Now, I know you've not done echoes, but I will tell you the findings. So this, okay, let me see if I can escape my pointer so I can play this. So if you see here, this is left atrium, left ventricle, right atrium, ventricle, and we have a small ASD. Now, why do we say small? Because right atrium, right ventricle are not dilated. So when would you operate on this patient? He has a small ASD, right atrium, right ventricle not dilated. When would you operate on this patient? Anyone? You can say anything, it's okay. Okay, would you operate on this patient? Let me put it the other way. Would you operate on this patient? Small ASD, no right heart dilation, 10-year-old. Right? Well, 10-year-old, so it's not going to close. I've given him natural history time. Now, see, generally ASDs, if they are going to close or become smaller, they close in the first 3 to 4 years of life. After that, they don't close. I mean, it's very, very unusual to close. So generally, that's why if you have an ASD at birth, we try to follow till 3, 4, 5 years, because that's when they close. If they don't close by 3, 4 years, generally they're not going to close. So this is a 10-year-old, it's not going to close. So would you operate? Would you not operate? And the answer is, I would not operate. This child does not need intervention. Why? Because there is no right heart dilation. So if there's no right heart dilation, there is no need to close. No right heart dilation, no need to close. Why? We know that 1 out of 5 people in the world have a PFO, right? That is also a small connection. No right heart. Are we closing all of them? Are we sending them all to the device closure? No, right? So if you have a small secundum ASD, RA-RV are normal, that means that QP, what we say is QPQS, pulmonary blood flow to systemic blood flow. Only when pulmonary blood flow is 1.5 times of systemic blood flow are we going to operate. If QPQS is 1.5 times, then you will have right heart dilation, right? So now let us say my systemic blood flow is 5 liters per minute, right? If my pulmonary blood flow is 6 liters per minute, that is a QPQS of 1.2:1. It's not very high. There's going to be no right heart dilation, and that little extra flow is not going to cause pulmonary hypertension in the future. Before you can get pulmonary hypertension, first your RA-RV has to get dilated, right? Left atrium to RA, RA gets dilated. RA to RV, RV gets dilated. RV to pulmonary artery gets dilated. Then pulmonary hypertension happens. It's a cycle. It has to, flow has to go. If RA, RV are normal, why will he develop pulmonary hypertension, right? So when you have a small secundum ASD, no right heart dilation, no need to close. So when you are sent an echo report from a cardiology place or someone has done, and if they write 5 mm ASD, RA normal, RV normal, but device closure, please get a second opinion. Okay, so this is on small ASDs. Similarly, PFO. Now, there is one indication to close, that is if they have a paradoxical embolus, if they have a stroke, those are different. I am saying whether you close asymptomatic just based on him having an ASD, and the answer is no. Now, let's go to the next. This is secondum ASD, which is moderate or large, right, which has a load on the right heart. Those are the ones you're going to close. We do a surgical closure. You go see here. Let me get my laser pointer back. You can put a patch and sew it, or you can just do it like this and do direct. So if it's like this, you put a patch. If it's like this, you can just sew it. The way if you have a hole in your clothes, you sew it. So direct closure or patch closure. If you're using patch, you can use the patient's own pericardium or Dacron or PTFE. Nowadays, either we do sternotomy, we can even do minimal access under the breast, lateral from the side, so that you don't see it with the sari blouse, especially for female patients. So your surgical procedures are dependent. You can do direct closure or patch closure, you can do sternotomy, minimal access, you've got many options. Now, device closure is a very well accepted, this is not experimental. I trained in the US at Yale University. I did my pediatric cardiologist in 1995. So I'm a buddhi. So in 1995, we had started doing device closures. So that is now 25 years of device closure. It is not experimental. It is approved by FDA. And there have been millions of devices put into patients all over the world, including lakhs of them in India every year. So this is the device. You have this sits on the left atrium. This sits on the right atrium. So it's like a sandwich. The ASD is like the cucumber, and the device goes and holds that ASD. So it's a very well accepted modality. Now, anyone knows what the device is made of, what material? Because patients will ask you this. So this is how the device looks. When you deploy it, this is done in the cath lab. There's no cutting. You go from the leg, you put a catheter into the heart, you put this in the left atrium, you put this in the right atrium, you push, pull, make sure it's sitting nicely. Then you see this cable is attached. Once you're happy with it, you release it. So anyone, what material device is made of? Because a lot of patients, everyone fears foreign body, you know. But this is made of something called nitinol, which is basically nickel titanium alloy. Mostly 99.999% the body tissue does not react against it. Now within this, there is Dacron polyester, and it takes about 6 months time for the body tissue to come and cover over this device. So that is why for the first 6 months after procedure, we put them on aspirin. So why do we put on aspirin? While this, the endothelialization is happening, the body tissue is covering this ASD, little clots are forming in the device, which can embolize. So that's why for first 6 months, they stay on aspirin. Now, what do we tell them after the device closure? We check vitals, we keep them in the ICU for 6 hours because we make sure it doesn't fly off. Like see here, you see this device, now it's been released. You saw the last one, it was attached. You see this cable, right? Now you see here it's been released. So we have to check echo, make sure it's not by chance embolized, gone off to aorta, gone off somewhere else. So we check vitals, we monitor the femoral pulse, we check the ECG, and we discharge them next day with aspirin and endocarditis prophylaxis for 6 months. 24 hours later, 1 month later, 2 years later, for post complications of ASD device. You can name any complications. Because this is something families will ask you. So I always tell them, in today's day and age, they've become, as our expertise has improved, the percentage of complications has reduced. And obviously, any procedure has some complications. So anything you can think of, putting a device in the heart, any complications. So heart block would be one. And if we see heart block, we immediately remove the device. Yes, anything else? Embolization, I told you. So there is a long list of possible complications. Major ones are arrhythmias, such as heart block or SVT, perforation of the heart, device embolization, tamponade, obviously a stroke, if you by chance, unfortunately, don't anticoagulate properly and a clot forms, and very, very rarely death. And minor complications would be your anesthesia reaction, blood loss, and so on. So while there are complications, this is a relative procedure. It's a one-day procedure, no incision, and the complication rate today is really less than 1%. Now, which ASDs are suitable for device? So obviously, we would like to do device in everybody, right? But we can't do it. I told you it's like it holds on here and it holds on here. So you can do it in ASDs. And that too secundum ASDs which have tissue here. For the device should hold on to something, right? So that's something we look at. We make sure that there's a lot of, rim on each side. It shouldn't impinge on the pulmonary veins. It shouldn't impinge on the mitral valve. There shouldn't be associated mitral valve problems. Those are suitable for device closure. Which are not suitable would be your primums, your secundum, your sinus venosus ASD, or your secundum ASD that don't have enough rims, or it's too big an ASD in a small child. Like for instance, if it's a 2-year-old child with a 20 millimeter ASD, right? If it's a 20 millimeter ASD, we have to put a 34 millimeter device. The whole atrial septum may only be 22 millimeter. You can't stick a 34 millimeter device. So in smaller children, in pediatrics, we cannot close very large ASDs. So this 24 mm ASD, you can close in adolescents and adults. You can't close in a 2-year-old. So one has to be careful in the device selection also. So as a pediatrician, it's important to tell the parents that there is an option of device and surgery. Device depends on the type of ASD. It depends also on how the tissue is and whether there's enough tissue and space for the device to sit. So that we will let the cardiologist determine. Because sometimes I get a patient, they've decided they want device. Now it's not suitable for device. Right? Then we've got to explain to them, if we do an unsuitable ASD and stick a device, we may cause more complications. So in that case, surgery is safer. So it's very important for both pediatricians as well as cardiologists to speak the same language, to be telling them, cardiologists, if it's suitable, we'll try device. If not suitable, surgery. Device is not experimental. If it is suitable, please go ahead with device, because it's been around now for 25 years with very high success rate. So diagnosis here, anyone? This is an echo, sinus venosus, what is called the subcostal sagittal view. You can see here IVC, SVC, and you can see here, this is the sinus stenosis ASD, very high up. And typically these are associated with this right upper pulmonary vein, which should go here to left atrium. It goes into the SVC. So it's a sinus venosus with a what's called a partial anomalous pulmovenous connection. Now, treatment for this is only surgery. There is no device, right? So if you see here, what you do is basically you have to, either you can patch it, you connect the vein back to LA and close the ASD, or there is something called a Wardens, where you cut the SVC above pulmonary veins, connect that SVC to right atrial appendage. So that's a more complicated one. But the important thing you need to remember is look where the sinus venosus ASD is here, right? Look at SVC. So when you do, if you do some connection through SVC, right? Same SVC is how much? 5-6 mm? You can cause SVC obstruction. And this is why sinus venosus ASD, we have postponed operation to 4 or 5 years because of this issue. Because if you're going to be going through the SVC, you can cause SVC obstruction. There's also the sinus node is very close. You can have sinus node dysfunction. So we check them every year. As long as lung pressure normal, we try to postpone intervention. Now, nowadays, with this Warden procedure, we are getting by with doing even 2- and 3-year-olds. So if a 2-year-old has lung pressure is high, we can still operate. But if lung pressure is normal, no symptoms, we try to postpone. Unlike in secondum ASD, where the risks are much lower of operation. Now, this is a primum ASD. If you see here, this is the left atrium, left ventricle, and you have a ASD with mitral regurg and tricuspid regurg. So treatment, as I said, this is also again surgical, no question of device. And typically we do it at 1-2 years. Why? Will primum ASD close? Never. Primum ASD can never close. Sinus venosus ASD can never close. So generally when at birth they are diagnosed with primum ASD or they are diagnosed with secondum ASD, we know they will need operation, right? So it is better we counsel them, it will need operation. Timing of operation, we will keep checking and deciding. Now, why is it primum ASD we are doing early? Reason is, if you see this echo, most of them are associated with what is called cleft in the mitral valve, because this is an endocardial cushion defect. When you have a cleft in the mitral valve, you have mitral regurg. That mitral regurg will also go left to right, right? You will have not only the LA to RA, pulmonary vein blood going left to right. Now MR blood is also going left to right. So they can develop earlier pulmonary hypertension, earlier vascular damage. So primum ASDs, we need to operate, and typically earlier than secondum ASD. For secondum ASD, why are we waiting? Because maybe Allah, Jesus, right? Shiva, Vishnu, some Lord is going to make it smaller. So in secondum ASD, we are waiting because there is a chance it can become smaller. Primum ASD, we know it cannot become smaller, and we know they can get early pulmonary hypertension, so we operate early. Sinus venosus ASD, we know it will not get smaller, but we know the surgery is a little more complicated. We know they can get sinus node dysfunction. Maybe you have to baffle through SVC, get SVC obstruction. So we postpone. So a lot of the timing of intervention is based on the type of ASD. But if you are postponing, we have to keep checking year on year that the lung pressure is normal. Okay. Now, if we have missed in today's day, and I hear in Kerala, you all hardly miss diagnosing. You don't, you diagnose very early, but in other parts of India, they diagnose late. When would you be worried that we have missed the boat with ASD? Now, patient has got lung damage and I cannot operate. When would you be worried? What features? So you see, once the lungs are damaged, you close the ASD, it doesn't help. And what will happen? The blood cannot go to lung, it cannot go through ASD, they will have right heart failure and earlier death. So once they become Eisenmenger with ASD, we cannot operate, right? So what feature? Tell me one feature with ASD you would be worried. You saw there's a note when child was 3 years old, its saturation was 100%. Today's saturation 70%. That kid is very worrisome for inoperability. So cyanosis, one thing from clinically is cyanosis. Except if it's a common atrium, that's a different issue, right? But a secundum ASD, primum ASD who's now cyanosed is very worrisome. Then, of course, from cardiology perspective, we will look at his cath and his, all his other features for operability. So I'm going to close with this. So let's again do the same question. Now, this I want all of you to answer. Now, when would you close the following ASDs with right heart dilation? So you see here, I have put with right heart dilation because if you have primum ASD, no right heart dilation, no closure. Secundum ASD, no right heart dilation, no closure. Let us get this very clear. If you have primum ASD, I've had, even my own PGs say, but it is primum, we should still close. But if there is no RARV dilation and there is no mitral regurgitation, what are we closing for? We close an ASD so that we prevent pulmonary hypertension in the future, so that we bring down the RARV dilation for them to have a normal life. If there is no RARV dilation, why do we need to close? Then the only indication to close is if they are at risk for paradoxical embolus. Now, paradoxical embolus, we cannot be closing all the PFOs of the world, right? I won't have time to give you a class. I'll be in cath lab closing PFOs. So there is no indication to close. The only thing we advise them is don't go deep sea diving where there is a chance of bends, the bends and the bubbles going right to left. That's the only advice for the PFOs and small ASDs. So if you have an ASD with right heart dilation, when would you close? Okay, secundum ASD, 2 to 5 years. Sinus venosus ASD, sinus venosus ASD. No, everyone has to answer now. Otherwise, I'm not moving to next question. This is final slide. Sinus venosus, 5 years, 4 to 5. Primum ASD, good primum ASD with MR, with right heart dilation, 1 to 2 years. You want to remember, one, it's okay, you can have a range, no problem. Typical symptoms in a 3-year-old with ASD. Typical symptoms. So asymptomatic, or they can have respiratory infections and low weight gain in a small percentage. When do symptoms typically occur in ASD? When do symptoms typically occur? 3rd or 4th decade with PH. Which ASD can be closed by device? Or CSD with good rims, right? How would you decide on surgery versus device for secundum ASD? So which ASD can be closed by device? Secundum. How do you decide that secundum can have surgery? What do you look at? You're going to look at the rims, right? You're going to look at the rims and make sure that you have enough and also that it's not too big for closure in pediatrics. So rims and size. Okay, so with that I shall end and let you get on with your day. Thank you very much. If there are any questions, we can take it now. If not, feel free to email me and I can answer any of your questions. Okay, so with that, we'll end the class. Have a wonderful day. I'll stop sharing then, Abhilash. Yeah. Okay. Ciao, ciao. Oh, you're welcome.
Thank you, ma'am.
Okay. Ciao, ciao.
Our